Welcome to our first video on diseases of the thyroid gland. Let's begin. Here's an overview slide of what we'll discuss in this lecture. Let's start with hyperthyroidism. We'll discuss definition, etiology, risk factors, clinical presentation, diagnosis, treatment, and complications of hyperthyroidism. Hyperthyroidism is defined as excessive production and secretion of thyroid hormones by an overactive gland. To expand on it further, let's address the pathophysiology of hyperthyroidism. In hyperthyroidism, the thyroid gland secretes large triiodothyronine T3 and thyroxine T4 quantities due to inflammation or stimulation by the antibodies. This gives negative feedback to the pituitary gland, suppressing the thyroid-stimulating hormone release. That's why hyperthyroidism typically results in decreased TSH levels. Thyroid hormone increases metabolism, and that's the principal reason for most symptoms in this condition. There are several causes of hyperthyroidism. We can start with Graves' disease, an autoimmune disorder in which there are autoantibodies activating the TSH receptors and stimulating the thyroid gland to produce more thyroid hormones regardless of TSH levels. This condition is the most common cause of hyperthyroidism. Toxic adenoma presents with a hyperthyroid state and results from focal hyperplasia of thyroid follicular cells. On the other hand, diffuse hyperplasia of thyroid follicular cells leads to multinodular goiter. In both conditions, toxic adenoma and multinodular goiter follicular cells have autonomous activity and produce thyroid hormones independent of TSH levels. Thyroiditis is caused by inflammation of the thyroid tissue and may present as an initial hyperthyroid state followed by recovery or hypothyroidism. Finally, exogenous use of thyroid hormone can also be a cause of hyperthyroidism. Let's talk about some important risk factors. Actually, several factors have been proposed in Graves' disease, but the most important one is the genetic susceptibility associated with HLA-B8 and HLA-DR3. For toxic adenoma and multinodular goiter, the exact etiology is unknown. However, both of these conditions are more common in iodine-deficient populations. We will use this image to discuss the clinical presentation of hyperthyroidism. In normal states, thyroid hormones stimulate the metabolic activity in most tissues of the body. In hyperthyroidism, the metabolic rate gets too high, causing a vast constellation of symptoms. The major consequence of this is the increase in heat production, which results in sweating and weight loss. Other examples of metabolic effects include increased lipid metabolism and utilization, which leads to a decrease in HDL, LDL, and total cholesterol. Additionally, thyroid hormone increases the expression of beta receptors, which raises the heart rate, contractility, and stroke volume, thus raising the oxygen demand. This may precipitate arrhythmia like atrial fibrillation, the most common arrhythmia in hyperthyroidism. Moreover, beta-adrenergic activity can cause fine tremors and diarrhea. Finally, the high rate of catabolism and protein degradation may cause myopathy, which commonly presents with proximal weakness. However, creatine kinase levels remain normal. These patients are also at risk of developing osteoporosis because T3 can directly stimulate bone resorption. Besides, Graves' disease may have specific features because of the TSH receptor autoantibodies present. It presents with a classic triad of goiter, pretibial myxedema, and exophthalmos. Fibroblasts play a major role in the development of these symptoms. Circulating autoantibodies can stimulate TSH receptors on fibroblasts and induce them to secrete glycosaminoglycans. The accumulation of this material in specific tissues causes pretibial myxedema and exophthalmos. Here's an image that shows pretibial myxedema, a classic finding of Graves' disease. As we can see in the picture, pretibial myxedema presents as non-pitting edema, meaning there is no water movement in response to pressure because glycosaminoglycans fill the tissue instead of a transitate. Glycosaminoglycans can also accumulate in the extraocular muscles and retroocular connective tissue, resulting in exophthalmos, which refers to the bulging of the eyes. This is a good image of exophthalmos that is extremely common in patients with Graves' disease. Let's try a question. A 45-year-old woman presents to the physician reporting palpitations and excessive sweating for 3 months. She also complains of difficulty falling asleep. The physical exam reveals bilateral non-pitting edema of the anterior tibia. Laboratory findings are significant for TSH levels of 0.1 and positive anti-TSH receptor antibodies. What is the most likely mechanism of the physical exam findings in this patient? This woman with palpitations, excessive sweating, and difficulty falling asleep has low TSH of 0.1 and positive anti-TSH receptor antibodies. These are the classic findings for hyperthyroidism due to Graves' disease. The physical examination reveals bilateral non-pitting edema on the anterior tibia. This phenomenon is known as pretibial myxedema. Now let's discuss the mechanism of developing pretibial myxedema in Graves' disease. anti-TSH receptor antibodies stimulate TSH receptors on the dermal fibroblasts. Dermal fibroblasts in turn release glycosaminoglycans. The accumulation and deposition of glycosaminoglycans in skin causes swelling and non-pitting edema known as pretibial myxedema. Let's move forward with a workup of hyperthyroidism. If the patient has signs or symptoms of hyperthyroidism, such as tachycardia, diaphoresis, and tremors, first, thyroid-stimulating hormone levels should be obtained. Serum TSH is most of the time the best initial test. If the value is normal, it is unlikely that the patient has thyroid problems, and the physician should think about other possible diagnoses. If it is increased, we should suspect secondary hyperthyroidism, likely due to pituitary adenoma. However, if we get a low TSH, we should also obtain free thyroxine, FT4, one of the two thyroid hormones, and the most important of these because it shows how much the thyroid is working in response to TSH. Triiodothyronine, T3, is sometimes useful when TSH is low with a normal FT4. If FT4 and T3 are normal, we should suspect subclinical hyperthyroidism and follow up with the patient to repeat TSH in 6 to 12 months. However, we can repeat TSH sooner if the clinical presentation changes. If FT4 and T3 are elevated, or only FT4 is elevated, hyperthyroidism is confirmed. Then we proceed to test for TSH receptor antibodies. These antibodies are common in patients with Graves' disease and are responsible for some of the classic symptoms in this condition. If the patient tested negative for these antibodies, we should perform a thyroid scan. If the uptake is increased, then we have 3 possible outcomes. First, when the thyroid has a diffusely increased uptake, this suggests Graves' disease. Other possibility could be to find either a focal uptake, which means that it is a toxic adenoma, or a patchy uptake that is suggestive of toxic multinodular goiter. On the other hand, if the thyroid gland has a decreased radioactive iodine uptake, then we should think about the thyroiditis, which will be covered later in the lecture. Let's continue with the treatment of hyperthyroidism. There are multiple treatment strategies, including pharmacologic agents, radioactive iodine, or surgery. For pharmacologic treatment, multiple medications can be used. First, we have thionamides, which inhibit thyroid peroxidase and the organification of iodine. Methimazole and propylthiouracil are the most commonly used thionamides. Propylthiouracil also inhibits the conversion of T4 to T3. Agranulocytosis is a serious but rare side effect. Due to its seriousness, this is a frequently tested adverse effect of these medications. It is also important to note that we cannot use methimazole in pregnant women during the first trimester because it is a known teratogen. On the other hand, propylthiouracil is very hepatotoxic, which is important to know. Then goes beta blockers such as propranolol or atenolol. These must be started as soon as hyperthyroidism is diagnosed to control adrenergic symptoms such as palpitations, hypertension, fine tremors, and sweating. Lastly, steroids like dexamethasone are used if the ophthalmoplegia is causing diplopia or if the patient is at risk of vision loss. Radioactive iodine therapy is a definitive treatment, but it must be used carefully. It may worsen the ophthalmopathy because of the rapid induction of hypothyroidism, resulting in increased secretion of TSH and TSH receptor stimulation on the already abnormally proliferated retroorbital tissue. Finally, surgical intervention is reserved for patients with very large goiters or those who cannot use radioactive iodine, such as pregnant women. Finally, let's move forward with a life-threatening complication of thyroid toxicosis, thyroid storm. It usually follows some precipitating factors such as infection, surgery, trauma, or diabetic ketoacidosis. It is unclear why all these factors can cause a thyroid storm, but it seems like all of them stimulate the adrenergic activity of the sympathetic nervous system. Sympathetic nerves innervate the thyroid gland, and their secretion of catecholamines stimulates thyroid hormone synthesis. Large quantities of thyroid hormones increase the expression of beta-adrenergic receptors, enhancing the effects of catecholamines. This creates a never-ending circle of adrenergic effects, causing most clinical features such as fever, tachycardia, hypertension, psychosis, agitation, and delirium. In order to manage this condition, the patient should be admitted to the intensive care unit. Beta blockers should be given as soon as possible to control the heart rate. A high dose of thionamides and corticosteroids should also be administered to impair peripheral generation of T3 from T4. Potassium iodine can be given to block the release of T4 and T3 from the gland. Let's do a quick question. A woman with Graves' disease presents to her obstetrician to discuss family planning. What are the treatment options she has while being pregnant? Common treatments for Graves' disease include radioactive iodine and thioamides. In the case of pregnancy, radioactive iodine is contraindicated. This is because by 10 to 12 weeks, fetal thyroid tissue has begun to develop and would be ablated by the radioiodine. In choosing the thyroamides, it is important to determine the gestational age. PTU is recommended during the first trimester due to the congenital malformations caused by methimazole. After the first trimester, the patient may be switched back to methimazole due to the high risk of hepatotoxicity. Patients who are allergic to thionamides or those who have persistent symptoms despite treatment with antithyroid medications are also candidates for surgery, though in the case of a pregnant patient, this would not want to be performed until the second trimester. Now let's dive deep into hypothyroidism. In hypothyroidism, we'll discuss definition, pathophysiology, causes, clinical presentation, diagnosis, and treatment of hypothyroidism. Hypothyroidism is defined as the inadequate secretion of thyroid hormone due to a hypoactive thyroid gland. Let's go back to our diagram showing the interplay between hypothalamus, thyroid gland, and other tissues in order to explain the pathophysiology of hypothyroidism. In hypothyroidism, the thyroid is not able to secrete T4 and T3 due to atrophic or non-functional tissue. Subsequently, the negative feedback to the pituitary gland is suppressed and TSH secretion is increased. The lack of thyroid hormones decreases the basal metabolic rate, which is the major reason for most symptoms in this condition. Let's discuss the causes of hypothyroidism. Of these, Hashimoto thyroiditis is the most common one. It is associated with antithyroid peroxidase and antithyroglobulin autoantibodies. Moreover, it has a genetic association with HLA-DR3 and HLA-DR5. Iatrogenic hypothyroidism due to radioactive iodine ablation of the thyroid tissue and thyroidectomy is also common. Lastly, thyroiditis, which is an inflammation of the thyroid gland, may present as transient thyrotoxicosis due to the release of thyroid hormones. However, the eventual depletion of hormones and loss of function of the tissue may result in hypothyroidism. We're going to use this image to discuss the clinical presentation of hypothyroidism. Just like hyperthyroidism, hypothyroidism has a wide range of symptoms. Hypometabolic state of hypothyroidism leads to some abnormalities such as fatigue and hair loss, depression, cold intolerance, constipation, weight gain, bradycardia with decreased cardiac output, and myopathy. Please note that the creatinine kinase level is increased in hypothyroidism. It can also present with non-pitting edema due to the deposition of glycosaminoglycans secreted by fibroblasts. Recall that hypothyroidism leads to increased secretion of TSH, which in turn stimulates fibroblasts to secrete glycosaminoglycans. Now we'll discuss the workup and management of hypothyroidism. The best initial test when suspecting hypothyroidism is serum TSH. If TSH is low, we should evaluate for secondary hypothyroidism, maybe due to a pituitary tumor. What happens if the TSH levels are high? We should obtain free T4. Remember that FT4 is very important as it shows how the thyroid gland is working in response to TSH. If the FT4 is normal, we should consider subclinical hypothyroidism and reassess the patient 6 to 12 months later or sooner if the clinical situation changes. But if it is low, primary hypothyroidism is highly likely. We proceed to test for thyroid peroxidase antibodies, as these antibodies are commonly positive in patients with Hashimoto's thyroiditis. If the patient tested negative for these antibodies, we should think of any other cause of thyroiditis, such as de Quervain painless thyroiditis or Rydell's thyroiditis. In order to treat hypothyroidism, we have to start thyroid hormone replacement therapy with levothyroxine and regularly reevaluate TSH levels to assess the response. As we've already mentioned, the most common cause of hypothyroidism is Hashimoto's thyroiditis, also known as chronic lymphocytic thyroiditis. In this condition, we can find diffuse parenchymal infiltration by lymphocytes, particularly plasma B cells, often seen as germinal centers. Patients with this condition are at increased risk of thyroid carcinoma and thyroid lymphoma, likely due to the chronic antigenic stimulation leading to malignant transformation. Let's solidify important concepts with some board-style questions. A previously healthy, nulliparous 35-year-old woman comes to the physician because of a 6-month history of irritability, frequent bowel movements, and weight loss despite no changes in appetite or diet. Her pulse is 120, respiratory rate is 16, and blood pressure is 122/80. Physical exam shows moist skin, proptosis, and fine tremors. The thyroid gland is diffusely enlarged. Laboratory study shows a thyroid-stimulating hormone concentration of 0.1, thyroxine concentration of 26, and antibodies against the TSH receptor. Which of the following therapies can worsen the patient's exophthalmos? A. Propranolol, B. Methimazole, C. Radioactive iodine, or D. Steroids. This patient complains of irritability, frequent bowel sounds, and weight loss despite no changes in appetite or diet. This is likely suggestive of a hypermetabolic state, the hallmark feature of hyperthyroidism. Furthermore, the thyroid gland is diffusely enlarged. This, combined with low TSH, high T4, and antibodies against the TSH receptors, should make us think of Graves' disease. All of the mentioned medications can be used for the treatment of Graves' disease. But let's try to recall which of the following therapies may worsen exophthalmos. The answer is C, radioactive iodine. Remember that one of the adverse effects of radioiodine therapy is that it may worsen the exophthalmos by the rapid induction of hypothyroidism, causing increased secretion of TSH. Let's discuss other answer choices. None of the other medications have been linked to the exacerbation of exophthalmos. However, let's go through their side effect profiles, as side effects are frequently tested on step 2, CK exam. Propranolol is used to control beta adrenergic symptoms. However, blockade of beta-2 adrenergic receptors can trigger COPD or asthma exacerbations in susceptible patients due to bronchoconstriction. Methimazole has been linked to granulocytopenia and teratogenic effects. Steroids alleviate exophthalmos and are used for treatment of this condition as they decrease inflammation and swelling. And that concludes this section.